Welcome to Understanding Healthcare with Zach Cantor. I'm your host, Zach Cantor, and with me today we have Ayo Amandla, who's the co-founder and CEO of Substrate, which builds AI agents for healthcare revenue cycle management. And today we're going to talk about all things RCM and beyond. Great to have you on the show.
Thank you for having me. It's a pleasure.
Would love to start maybe with an explanation of what Substrate does and who's it for. Who what's the kind of prototypical customer that you guys have?
In a nutshell, we build automations for revenue cycle, and our mission is to help providers get paid more quickly. That's a pain I've unfortunately felt for a long time. And the prototypical customer is if you are a practice that has basically a large labor organization running collections for you, that that could be a large health system, a scaled up physician group, an outsourced biller. All of those are in play. We focus very heavily on the physician groups and the health systems, but that's who we're for.
Common question that we hear from people is where exactly would you say that the revenue cycle starts? So when you're saying you guys do RCM automation, is that starting at patient intake? Where's the beginning of this?
So yeah, actually, philosophically, I actually think revenue cycle starts at contracting, because that's just determines. It's like your price list, effectively, is what that entails. We're fairly specific. We don't touch everything. There are, if you start all the way, it's contracting, credentialing, registration and intake, authorization, and then an encounter happens, and then there's a bunch of process between an encounter and a claim, and then we pick up after the claim has been submitted, and run all the way to the end. And there are many reasons for that, but the probably most practical one is, each of these domains are actually very, very hard problems to solve the way we want to solve them. We the thing we sell, and I say this to clients all the time, is we sell results. Like we sell an atomic unit for work for us is the action that needed to happen for the claim to get paid. We are doing it. And if you're trying to do that across the whole revenue cycle, you end up being kind of an inch deep and a mile wide. And I think it's really, really hard to be good if you're doing it that way.
It makes total sense. Do you find is that a pretty easy thing to navigate with clients, or are they often asking you to solve more?
They're always asking us to solve more, and we probably say no more than I would like, if I'm being honest. And if you think of the types of organizations that we work with, they're just dramatically large, and so what ends up happening is, when we show up at their doorstep, it's probably 3 times out of 10 where the problem that they have at that moment, the burning fire for them, is a problem that we solve. So, we have a handful of large clients we worked with who are like, they had a denials problem. We've helped, reduce that or make it go away in some cases. And they're like, hey, do you do prior auth? And I'm like, there are 50 companies doing that and they've raised $1 trillion. Like, go, please.
We get the prior auth question a lot too.
Yeah, I'm ready to use whatever that prior auth transaction you guys have like coming later in the year. Like we are very, very ready to use it whenever it arrives.
Awesome. The X12 278 and then the DaVinci prior auth fire prior auth stuff is coming down the pipe eventually. The you said it was a pain that you had experienced for a very long time. How'd you come across the pain?
So I spent 5 years running product at Carbon Health, and it was my first role in healthcare. I joined February 12, 2020, and I'd just come back from Asia, where I'd seen just the mask in the month before when I was in Asia, the mask wearing was like progressively more aggressive. And at Carbon, we scaled dramatically. Like we went, I think over a year and a half, we went from like 7 clinics to 150, and from like 7 in revenue to over 200. And what I didn't know when that was happening is that we were not a mature collections organization. And so, the joke I make sometimes is that we basically took a bunch of capital that we raised from venture and gave this to the pandemic. We vaccinated like 2 million people. We vaccinated like 1% of the state of California.
Wow.
And we had this value that was, we called it assume karma exists. We were like, hey, we're just going to do the right thing and the business will work itself out. And it just turned out that was not at all true. And it turns out that, many responsible parties in healthcare are very comfortable with somebody else footing the bill for care. And so the way that I felt it personally was in 2023, I kind of turned my eye away from growth to revenue cycle. And, we looked at our, gargantuan backlog of AR and realized that for much of it, we were not going to collect. So I'll dig in on this for a second. One of my first experiences was in RCM was during the pandemic, the HRSA, the way that care was described around vaccines and tests was that they were free. And that's like what patients walked in expecting. And the way that that was implemented was that the patient's plan would pay. And so what would happen, and one of the things Carbon did was we ran the Dodger Stadium vaccination program, which was like the largest vaccination program in the US. People would show up and just be like, hey, I don't have any insurance, because they were like, from their perspective, it was free. And we'd be like, okay, like we'll bill the government. And we had these giant files that we would get back from the HRSA that said, hey, Zach showed up on January 1 for a vaccine. We sent it to the government, and the government would be like, Zach actually has insurance, so go collect it from them.
And would they tell you what the insurance was?
They would not.
Okay. Yeah.
And so one of my first thing was, I was like, wait, somebody out there has a database of every insurance that a patient has in the US. Like, that exists, and we don't have access to it. Why? And so I spent like 6 months just trying to figure that out, and I never got anywhere. And I think it was Optum, and I just don't think it was like a thing that they were trying to sell to providers. And so I kind of got obsessed with this idea that, if you want to understand RCM, the single thread that is, this is not like a malice thing, but the single thread that describes why this entire industry exists is the payers don't want to pay a provider. And to them, you are cogs, and there is no downside to them. There's actually only explicit upside to denying, not paying, delaying payment. And as a consequence, there's like an entire industry that exists where, it's just zero sum, and providers have people clicking buttons. And then on the other side of the internet, payers have people clicking buttons. And so I was like, people shouldn't be doing this. Like, nobody actually enjoys doing this. And, a lot of ink is spilt over the death of the independent practitioner. And this is one of the reasons. Like, one of the reasons is there's obviously like the clerical burden that providers have faced, prior to the age of scribes, but there's also the financial burden the providers face, because they spend all day caring for patients and all night fighting for dollars. And that is why we exist.
It's interesting. You hear this kind of common story about, hey, the payers are incentivized to not pay providers. I think like there may be some of that going on. I'll push back a little bit where I see, I was speaking to someone who works at a large EHR, and they go to payers and they make the case for, we want access to your proprietary APIs. And I said, okay, great. But like, what is the ROI that you're showing them? And they said, well, one of the key things that we show them is that it reduces denials. And I said, reduces denials? I would have, naively, you think that the payer wants the opposite. The payer, if you say, hey, if you share this data with us, you can deny 20% more claims, but obviously that wouldn't be good for the EHR. And the answer that they gave was that the kind of machine that payers have to deny or reject claims is not really intended to reject or deny legitimate claims. And when legitimate claims get denied, providers call into the call center, or providers send emails, providers get frustrated, providers don't want to renew contracts, and same for the patients. So I think, like, I would ask, like, do you think how much do you agree with that, and how much do you think that no, there actually are incentive problems where there's some degree to which that is true, but there's also just payers don't want to pay claims?
It's good feedback. So I would say two things. I would say it can be and not or. And if you think of who the current like friction laden environment favors, it just favors day sales outstanding getting longer and longer.
Sure. Well, favors the person holding the money.
It favors the person holding money.
Yeah.
And so it's one of those, like, every person, and I actually do believe this. I actually do believe the people who work at payers, like, they believe in what they're doing, and they're not like, they don't wake up every day being like, oh, we want to shaft providers. But if the system was more efficient and more frictionless, they would make less money. And they are, capitalist entities with profit pools. That's not like we all as a society opted into that. So that's not like it's not a reflection on them. It's like we've made certain policy choices that have resulted in the environment we live in today. So, like, I think the point I'm trying to get at is not that it's like a malice thing. It's just structurally very beneficial. And that is like one of the reasons why, even in that example with the EHR, like, the system exists the way it does, with fragmentation it does, with the dispersion of data it does, because it like benefits the people holding the money. And I do not actually believe that technology is going to make it all go away. I do think, like, our mission is to increase the amount of the financial surplus available, so that can be spent on care. But I think, like, if we snapped our fingers today and every provider in the United States was perfectly efficient in the model that existed today, a new model would emerge that is not efficient. Like, I firmly believe that.
Can you give me an example?
A thing that surprised me when I started working in RCM is that we have, like, many, many electronic channels to exchange information. Yet some of the most impactful information frequently degrades into paper. And so I assume most of the listeners are familiar with this concept of a lockbox. And a very frequent pattern that we encounter today at Substrate, and we encounter frequently at Carbon, is you submit, patient comes in Jan 1, you submit the claim on Jan 2, it's Jan 16, and you haven't heard back from the payer. You go log into the payer portal, and the portal says, and I quote, "We sent you a letter telling you what to do next." You're like, wait a second, this claim is pending. We sent you a letter telling you what to do next. So now you're like, oh, now I have to, like, go into my lockbox, and, like, it's, this is changing now with some new software. But, like, back in 2023, you're like, oh, I gotta, like, go into my lockbox and, like, search for which letter from this payer tells me, for Zach's claim, what I need to do next. And it's usually, like, not that, it's not like there's 10 things you need to do. There's 3 or 4, but you have to know which one it is.
It just can't be represented electronically. It only
for some reason
only go on the medium of paper. Yeah.
It can only go on the medium of paper. And so I think, I think that all that's a long way of saying that the friction that requires a human in the loop is a feature, not a bug, of the system as designed today. And if there was not, if all of a sudden you managed to automate away 100% of the current tasks that humans were doing, by the way, I don't think it's possible, but if you're able to do that, new tasks would emerge that require a human. Like, it would, the ultimate way it would degrade is, this is like a really stupid example. You'd be, like, underpaid by, like, $1 or $2 on thousands and thousands of claims. And the only way you can resolve that actually is somebody at your organization has to call a payer rep, and good luck getting a payer rep on the phone for most payers.
Sure. Yeah. Well, we see this on the provider side too, where, we recently launched a paper claims API, and you observe people sending paper claims to payers who have accept electronic claims, and you ask why, and they say, well, we send our high dollar ones via paper because we feel like they take a closer look at it. Now, that may be true, that may not be true, I don't know, but there's it's one of these things where there's the human is human. Yeah, exactly right. So it sounds like when you started out from some of our conversations, when you started Substrate, you thought you were starting a different company, and that resonates. So did we. We started as an EDI platform and built a clearinghouse on top of it.
I do remember following you guys on Twitter way back in the day, pre-change.
And you're like, when are they going to get into healthcare and come save the day?
At the time, I was like, I didn't know what EDI was. And now obviously I'm unfortunately very acquainted.
Yeah. Well, it's interesting. Like a lot of people still, when you say EDI, don't really know what you're talking about. Now you can sometimes say the 837 claim and everybody knows what you're talking about, but the 837 is the EDI code it's the X12 EDI code for the transaction set and, inside baseball. So yeah, how did you guys get started?
Over my last year at Carbon, I spent basically a year and a half working on what I call like margin engineering. And so like the whole company was just focused on, hey, how do we get our costs in line? Where I focused most of my time was everything RCM. So we built a patient cost estimator that would predict how much a patient would owe. So we collected up front, and it was both the cost estimator plus the flow and language to enable a front desk to have that conversation comfortably. Optimize it.
This is basically for one CPT code, was it for many CPT codes?
It was for everything that would bill in urgent care or primary care.
Okay. Oh, okay. So more than just the COVID vaccine.
Yeah, more than just COVID vaccine. This was like all of this actually was post-COVID. This was just like we're just running an urgent care business. We got our patient collections from something like 55% to 99.8% over 9 months. We built a bunch of optimizations to insurance collections, got that from 77 to 97. We built a lockbox automation on some early GPT that would effectively treat the information coming in your lockbox as a claim status. So it would just like find the right claim, update it, include like a screenshot of the PDF, etc. And so we got to the point where I was like, oh, this is 2023 at this point. I'm like, oh, the world needs this agent thing. Like the world needs a thing where the only way to stitch these things together is something has to like sit on top of like the 4 browser tabs open, handle a lot of the copy paste workflow, and then reason about it to like do what's next. And, on the spectrum, urgent care is like not actually that complex clinically from a billing perspective. Like things like ortho and rheumatology are like way more complex. But for us, it, like even doing something that basic was like really, really hard. And so I basically left to build that. I left to build like this browser orchestration thing, because at the time the browser piece was what was difficult, or was what I perceived as difficult, and where the scarcity was. And so I left in August 2024, basically to focus on that body of work. And I thought what the world wanted was people to do the browser automations in RCM. And what I encountered instead was a field of broken dreams and promises, where healthcare operational leaders for years have been promised that like software would do these things and AI would do these things, and they'd only been met with disappointment. And so what we ended up building instead, and what we're in the middle of building, is a very, very hyper focused on the operational outcomes that these leaders need. And so like what we do is technical, but it's not like we take everything and throw it into like Claude. It's kind of like if there's very good software out there for a particular use case that we're doing, we'll just use that. Like we're just not we're very pragmatic about it. And the idea is we live and die by results, and what we sell to our clients is results. We say, you have this task before that took this long and cost this much, and we're going to make it happen instantly, reliably, for a third of the price. That's like the pitch.
And if I'm a client of yours, like what's the SKU I'm getting billed for on an invoice?
You are getting billed for a discrete task, for lack of a better way to describe it. And you can think of a task as, and one of the reasons I describe what we do is we go after these very scaled organizations is they typically will have specialized teams that will focus on payment posting, lockbox management, patient credit refund liability management, denial orchestration, et cetera, et cetera. So each of those we consider a task, and we have agents that do those things. Probably a little bit disjointed today because we've been extremely commercial and just focused on if we're going to write code, it must map to a problem that a client has. But to the clients, it's like very, very clear what they're getting billed for. And if I would say there's any friction that we encounter today, it's mostly they just don't believe what we say is possible, even though we know it is.
An example that would be like I'm getting an invoice for 5,200 appealed claims, or 6,500 payments posted, something like that.
Correct.
Got it.
Correct.
It's interesting when I didn't come from healthcare. I came from auto parts, and for my auto parts business, I got so sick of dealing with the EDI platforms that I had my own EDI system built, and it cost me $50,000. Like basically, like my upstairs, I lived in this apartment building. My upstairs neighbors at the time overheard me on a conversation with my brother complaining about the EDI platforms, and like 20 minutes later, I heard a knock on my door, and there's these two guys standing outside, and I opened the door, and they're like, "Hey, this is kind of weird, but we overheard your conversation, and like we're software developers. We live upstairs. Like, what are you working on?" And so I basically like moved into their apartment for 6 months. We built this EDI system. It cost me 50 grand, which is a huge amount of money at the time for small business. And when I started study, I said, I want to solve this for not just auto parts, but retail, logistics, transportation, supply chain, manufacturing, energy markets. It's like going to cost like at least 10 times as much to solve it for everything. And I was like, but just to be safe, margin of safety, I'll raise twice as much. And so I raised $1 million seed round. And, now I've raised $142 million. So you're like off by a lot. And I think
3 orders connected later.
Yeah. With your browser automation, you're like, this is like, okay, we had some like browser automations problems. I'll just build a generic browser automation thing. And, how hard could this be? The famous, words, how hard could this be? Turns out pretty hard.
Yeah. We do this not because it's hard, but because we thought it would be easy.
Exactly. I like the great flag that's hanging up in the facility. I think it's great. When you look at this, like you said, you focus on large folks. My naive guess would be, okay, why isn't this a self-service product that, the longest tail of providers can sign up for? Is because there's probably some setup required. Like what is the, what is it that prevents this? You've built this amazing technology. What stands in the way of this getting into the hands of like an individual provider's office?
So we do have self-serve. It's just a really high friction. You have to like get passwords, and it's primarily a function of like where we want to focus today. This is less a healthcare thing and more just like company building. Our early hypothesis, which I think has turned out to be true, is that the use cases for like the very large entities and small entities would be the same, but the sophistication of what you built would be much greater if you started with large entities first. And so that's, I wish I could say there was something really strategic about it, but it was very simple. Like do the big ones first, and that'll pay for you to build the right thing, and simplifying it is going to be easier than making it more complex.
It's fascinating you say that, because something that we just see over and over and over again is that there's so seldom a trade-off between we're saying, well, if we do this, it's good for small practices, but but that's bad for health systems, or well, health system needs things this way and somebody else needs things that way. Like you do see some configuration and differences there, but I'm surprised at how homogenous RevCycle is compared to other industries. At least like it's certainly I think some people who have only been in RevCycle might be horrified by that statement and say it's as heterogeneous as it can get, but it gets so much worse in the world at large.
Agreed. I think there's a tremendous amount of like what I describe as semantic similarity across the spectrum, and it's not just like large or small. It's like service delivery versus pharmacy versus sort of versus home health, etc. The semantic units are actually quite similar. And I think a lot of the differences, like the way we experience them, are in the interface. It's like if you're in one EMR or one PM and you're in another EMR or another PM, there's just a hilarious amount of variation. but to do the exact same financial task.
Yeah, it's like kind of semantically the same, syntactically different
Yeah.
in a way. Yeah.
Yeah.
Yeah, that's interesting. The you when you and I spoke before, you mentioned that like if you very much believe in getting into the complexity, and the way that we frame this is, every time you pick up a rock, there's three more rocks underneath it, which is a great thing. What you don't want to find in a business is that you pick up a rock and there's 0.9 rocks underneath it, because now you know that over time you're going to run out of problems to solve.
Now you know that Anthropic is going to take it away.
Yeah, exactly right. The you said something about going down the rabbit hole. Curious some of the rabbit holes that you guys have had to go down as you have gotten into some of the complexity of solving this narrow-ish slice. But even in the narrow slice, there's entire universes of complexity.
Yeah. I think, one, maybe I'll use a couple that are current. So, one of the things we're building, we call it a policy agent. And what it does is it takes an encounter and it takes the clinicals document that represents the encounter, like the visit summary and referrals and prior auth documents and so on. And then it finds the payer policy for that encounter, like the payer medical necessity policy for that encounter. And then it basically like breaks down that policy and tells you, oh, based on the way this encounter was documented, the payer would consider this medically necessary or not. And you can use that in a bunch of ways. You can use that like to qualify if you should do a procedure pre-visit. We actually built it primarily in the denials domain. When you read a policy, very often it refers to other policies down the line. It basically is like, oh, this policy governs these codes, but if you're doing this in conjunction with this other condition, you have to go read this other policy. And so the thing that we built is like just recursively trying to find the entire world and then break it into, a checklist isn't right, but like a set of criteria that a human can look at and say, hey, there are 6 things that had to be true. Only 5 are true. Let's go figure out if the 6th is true. Like if the 6th is true and just not documented, or if we need to go chat with the physician and update the thing. I would say that's like an example of when I started, I was like, oh, there's a policy, and like read the policy, and the policy gives you the list. and
oh, sweet summer child, as they say. Yeah.
Yeah, exactly. And that turned out to just absolutely not be true in any way. And what's ended up happening, the really nice thing, as we've rolled this out, is it turns out that it maps relatively cleanly to what the human has to do. And we like, I was sitting with a client looking at this maybe a month ago, and I was like, just show me, how do you actually get to it? And she literally was like, CVT code 36740 Humana into a Google search, and then like pulled up the PDF and was scrolling, scanning, doing searches, and then going the whole way. And I was like, huh. And so a thing I say to my team all the time, I feel like I need to write this. I call it like in defense of rabbit holes, is that like, if you're in a rabbit hole, go deeper. And if you're in a rabbit hole and you like look to your left and someone else is there, you're probably not actually deep enough, because that's a signal that like you're on, already trodden ground.
Yeah. When you Google something and there's no results, you're like, okay, now I'm in the right place.
Yeah, exactly.
Yeah.
Exactly.
Yeah, it's interesting. Like with this, you pick up a rock and there's three other rocks underneath it, or you're going down rabbit holes, and like most commonly we're down rabbit holes, and you're like, okay, I see like 5 other rabbit holes that are connected to this one, and there's nobody in any of those too. Is there like a moment that you can identify when you said, like, I'm sure there's been many moments that you won't talk about where you've said, oh no, this might not be a solvable problem. Do you remember any moments when you went down these rabbit holes and you said, like, oh, this is a solvable problem? Like where you see these kind of, it's the moment that you see the matrix and you're like, oh wow, the payer policy can be used in these 17 different ways. And yeah, we're doing this now for denials, but it's also going to be able to use in all these different ways. Are there moments like that that stand out for you?
I mean, the payer policy one is one where we started we started just like, hey, how do we tell if this denial is going to be paid or not? That was like the reason we built it. And then we realized that you can use that same concept for utilization management in the hospital when determining whether to move a person to the ICU to like a room or for a room to discharge. So I'd say that's probably one example. Probably, one from a few days ago is many organizations of many sizes share basically the semantic thing they're doing is the same. It's like you're working a denial, you're like resubmitting claims, same thing. But when you go under the hood, like the actual thing that happens, like the literal series of clicks that they do differs mostly at the interface level, but also like that organization might just have like a habit that they picked up because some person from 3 years ago did it that way and it worked. And I think we recently had one where, we're very happy customers of Steady, and we use Steady for claim status. And one of the problems inside in claim status is, this will take a moment to set up, but if you're a large multi-state organization that uses a single instance of an EMR, very often the person in Louisiana and the person in Rhode Island, when they like click into the field where the payer name is, the list that shows up, like the first 10 results, are the same, regardless of like where in the country that front desk person is. But obviously the Blue Cross Blue Shield in Rhode Island and the Blue Cross Blue Shield in Louisiana are like not the same entity actually. And the Blues are like actually kind of a bad example because they do, reasonably good routing. But one of the biggest sources of denials is you pick the wrong payer. And you pick the wrong payer, and from that payer you're actually able to get like a successful eligibility response, but you're not actually able to get like you shouldn't submit the claim there actually, and if you submit the claim there, it might get forwarded, but that'll delay your payments and so on. And so this is not meant to sound like an ad. A big part of what our claim status agent does is like trying to figure out like, hey, where should I go to get a successful claim status response?
There's a thread internally that we had just today about someone at the Steady's going to be having their first baby, and there's a thread about clearinghouse related baby books, and so one of them is, "Are you my payer?" Like, "Are you my mother?" And there's been some generated pages about trying to figure it out, and you send it and it comes back and it says member not found, and it says not the right payer, and COB and all this stuff. So very familiar problem.
Yeah, that's like that is like a low TAM book, but people would buy it.
Yeah. We're gonna have a whole second revenue stream of children's books related to RCM.
Amazing. So we had this experience where we're talking through this problem with the client, and she's like, "Hey, we have this problem where, for I think it was like in the Maryland, Virginia, DC area, Delaware, there's just the way those payers are contracted with this specific practice. There's like a rule set. There's a hierarchy you have to go through where like if it's this type of plan, you can bill through like the VA and Maryland ones, but if it's this one, you have to bill through Delaware." And she sent over like their SOP where they're like, go check the Care First portal instead of the Anthem portal or whatever. And we were like, saying one shot isn't technically correct because this agent's been around for a while, but we basically like kind of got 60-70% of the way there before like the document she gave us, like we'd already figured out a bunch of it. And I was like, okay, so we might actually like, we have, whatever the thing that Sam Altman and Dyer are doing, it is able to intuit some of this tribal knowledge. That is great.
Yep. Yeah. It's when you see, I think, that the leverage across customers and use cases, we see that in, okay, you uncover something in dental and you're like, oh, we have 80% of the infrastructure built out already for medical. And so it's just this, and it's when you can start seeing things like Lego blocks there's this great book called Complexity by Mitchell Waldrop, which talks about it's kind of like revolution in economic theory that came about in the 80s and 90s through the Santa Fe Institute. And they interview this biologist or something, and he says that like the key is inventing building blocks, because as you invent building blocks, like there's a great many things that you can invent, and build and invent and solve once you have the building blocks. And you know, I think a big part of what you guys are doing is building those building blocks. And sometimes you just have to kind of like build the amorphous blob that solves the problem. And then you go to the next person, you're like, there were 2 building blocks in there. And you could take those 2 building blocks and kind of pull them out and reify them and then reuse them in multiple different places.
Yeah, I buy that. It is it's very clear to me how the things all fit together when you have them. But sometimes it's rare to find people who like can put all the things together at once. There are a few out there.
Well, I think that's why you guys were selling this instead of, browser automation, is because people generally, I find, don't want some assembly required. I think that's changing a little bit in and when I say some assembly required, meaning some assembly required usually means like you're going to lose, you buy a piece of furniture, so some assembly required, you're going to spend most of your weekend assembling furniture.
Putting it together.
Yeah. And I think, to your point, people want solutions. And I think it's changing a little bit with AI, where, it used to be assembling something in the technology space was like often an insurmountable task to people. And, I had this moment, I don't know, 3 months ago when I was playing around with something with Stripe, and I set up a new Stripe sandbox, and I'm like trying to click ops the Stripe sandbox into the right thing, and I can't like get the connect to work or whatever the right way. And I was like, you know what? I was like, why don't I just point Claude Code? I was like, just give it an API key and point Claude Code and say like, configure the account the right way. And then it got it, and it got the setting, and I like went to the UI and the right checkboxes were checked and everything. And so this is changing a little bit, but I think generally like people want solutions.
Yeah. I mean, that is, it's funny you say that. It's like we never envisioned ourselves as an API product. And we recently have had a handful of, I'm like, I just didn't think anyone would want to write code to do this.
Well, we very much are an API product. And, and so, in some cases we sell to some people who say, I want some assembly required because, like there's people who say like, oh, some assembly required. And people say, some assembly required. It's like, it means I get to do things with it. And, but we've started seeing vibe coding small practices, just tons.
Yeah. I saw that post. It's pretty interesting, actually.
Yeah. It's crazy. As you guys, think about the kind of like the breadth and the depth. I would imagine there's like lots of depth that you can go into with the top 10 payers. But then I'd imagine also your clients, they have a long tail of payers and they want you to solve the problems for the long tail of TPAs. How do you think about the trade-offs there? Like, do you have a philosophy on concentrating on more depth in the Buka payers versus, getting some coverage or equivalent coverage all the way across the board?
Is Buka Blue United Cigna Aetna?
Yeah.
Oh.
I have a rule at Study, which is you're not allowed to use acronyms. And then somebody pointed out that I use a lot of acronyms. And I said, you can't use acronyms that I don't use. So this is also the rule on the podcast is no acronyms that I don't use.
Do what I say, not what I do. So at the level we operate at, there isn't that much of a trade-off yet. If you put a gun to my head, I would focus way more on the long tail payers, because I do think actually, and I'm thinking of like IPAs, TPAs, carve outs, workers comp, auto, because there are basically 0 people who like wake up in the morning super excited to wait on the phone for somebody at Sedgwick to tell them about the update. And so it's kind of like there's other work people want to do, and we are like freeing them of this tedium. That being said, I don't think there's like as much of a trade-off there as there used to be. And I do, this is not really a healthcare thing, but it does feel as though, I think one of the big promises of generated software, hybrid software, AI assisted software, whatever you want to call it, is that one, you can have software that's like actually like I think it's not you can have more features. I think it's more that you can have way fewer bugs, actually, is one thing. And then the second is um this breadth versus depth trade-off. Like the amount with which you have to make it is like actually way less.
But because you've removed the constraint on typing speed, basically, or
It's partly remove the constraint on typing speed, but a lot of what it takes to make the sort of the IPA thing or the TPA thing work is this like intelligence and tribal knowledge. You can accumulate it now much more quickly than you could before, and you don't have to. I think of one of the big differences between like software and the way that I grew up in it and like what's possible today is like all software is just rules, and before you had to like know what every variable could be before you created the rules rulebook. And the most expensive thing was you have a system that's like growing and scaling, and you insert a new variable type. And now you can move a lot more of that logic into natural language. And natural language is much easier to change, and many, many more people can change it. And as long as you have like a good set of fixtures and good evals, you can do that in a way that doesn't degrade your existing system. And so all that's a long way of saying, I think the payer trade-off is less acute than even I believed when we started the company.
yeah, we see something pretty similar, which is that people might have invested in getting their Blue Cross, Blue Shield, United, Cigna, Aetna, since I'm not using acronyms. They might have invested a lot in getting those processes dialed in, and they might have gone through the 270, 271 companion guides, and they might have gone through and created run books, and they might have the whole, something, a little script written for, not an actual script, but like a Google Doc or, Word doc with how you should do things. But like most people have not gone and done that for the 832nd most popular payer that they have. And so there's a lot of value in the long tail, which is like what makes it such a difficult business to start in any of these businesses, any RCM related business, RCM related services business, RCM related software business, RCM infrastructure business, is that like getting to 80%, like, it's like the first 80%, there's the second 80%, and there's like the third and fourth 80%. It's like there's I would say, it's interesting. Some years ago, I met an attorney who said like, who's in his like fourth decade of practicing. And he said that it was like, what keeps you practicing law? And he like thought for a minute, and he said like when you're starting out, like as an associate, like you learn one new thing like every 2 hours, and like, they're not super valuable, but you're like, stacking up these wins. He was like, I learn something new like once a quarter now, but like the thing that I learn is like the thing that you can only learn when you're 2 or 3 or 4 decades into the practice. And I think it's similar with RCM, where it's like you're panning for gold. This is like why we're crazy about support, is because like, when you guys open a support ticket with us, like we never know when we're going to get some piece of gold that we can turn into some like codified piece of logic.
Oh, that's so interesting. In that case, I have a lot more support tickets for you.
Please, we have metrics where we look at the people who spend the most money but submit the least few support tickets, because it's concerning for us, because we want people to ask more support questions, because it helps us get better.
Yeah.
Well, I have one question left for you. It's the closing question. Well, and I'm going to ask you one precursor question. I'm going to cheat first, which is, well, the closing question is, if you could change one thing about RCM without, upending all of healthcare, what would it be? But before you answer that, the question is, if nothing got better, like if we just froze in time, the models don't get, the AI models don't get better, the regs don't get better, prior auth final rule never rolls out, we never see single payer, no more shift to value-based care, whatever, nothing ever changes. How much better do you think the administrative side of healthcare can be from today?
Oh, I think there's like at least 5x improvement today. Like it's already true. I mean, I think, I contend, this is going to be my sales pitch. I contend that there's lots of, like in every practice today in America that does fee-for-service care, there is a human today that is logging into a payer portal, and they don't have to. 8 times out of 10, they don't have to. Machines can do this for them. And so I think even, I view what's happening today. I would say even with Steady, the world is so behind on what's possible, actually, like what people are doing today versus like the leverage they could get. The distance is so great that if everything froze today, just hold aside sort of the payer dynamic and the friction, there's 5x speed to get, there's 5x cost improvement to get, there's probably somewhere around 3x precision improvement to get. Like all of those are available with the technology that exists today. It's just a distribution problem.
100% agree. 100%. You see this when you watch somebody work and you're like, hey, did you know you could hit Command C, Command V to copy and paste? And they're like, and it changes their whole workflow. And before they were going and clicking, and it's that with payer portals, and it's that with, there's just thousands and thousands and thousands of these things. Okay. So then what are you waving for your magic wand, to make?
Oh yeah. What was the question? If there's
if you could make one change to revenue cycle management, without upending all of healthcare, what would it be?
I haven't thought about this super deeply, but I would if all you did was make it all electronic, that would be dramatic. Like basically no paper, no faxes, no letters. Everything has to be electronic.
What if everybody starts sending PDFs around? Does that count?
That's not electronic. No.
Okay. Yeah. Electronic, no PDFs. I think it's an important.
Yeah. Electronic structured.
Yeah. Okay. Yeah.
I feel like if you gave me an hour, I would come up with something better. But if you did that, effectively you did that, everything would be legible to machines, and the machines that we have are pretty good.
Do you think that like a machine readable, standardized, like payer contracts, payer policies, like do you have an opinion on which of these types of things would have the biggest impact?
Actually, I think the machine readable standardized insurance card would be, I think, the most impactful, because it would mean I think we talked about this at Carbon a little bit, and it never went anywhere. But just think of how crazy it is that today, when you go to Blue Bottle, you put a credit card down, and they're like, they know exactly the exact correct authorizing entity knows exactly which bank account to send money to. It's like amazing, right? But then you walk into a doctor's office, and healthcare is it's 100% TAM product. Like every person will consume healthcare at some point in their lives. And you put your insurance card down, and the person is like, huh, I've never seen one of these. It's a crazy, crazy, crazy concept. And so just if there was anything to standardize, I would say it would be that, actually.
There is something for this that I escapes me what state it's in, but it is called the Digital Insurance Card Project. And it is digitalinsuranceCard.org. And it's in some, I think, okay, so Evernorth is already using it on a limited basis. It sounds like there's some others that are working on this. So you may get to see that wish.
God, if only.
But it's, to the point of the discussion we've been having, if your nth TPA hasn't, implemented this, and it's, and it's just the 10 most popular plans, everybody recognizes the 10 most popular plans anyway. So it's kind of limited benefit.
There are United is already not a problem.
Yeah. Well, we have lots of customers who would say that it actually is pretty complicated. There's some things in there that are pretty complicated, but I get the message.
Fair enough. Can I turn this around for a sec?
Sure.
What is your answer to that question?
There's a common misconception that X12 EDI transactions, which is like the underpinning. First of all, it's a miracle that HIPAA adopted X12 and that we have these standards for it. There are some limitations to, like, I'd say I'm going to focus on the eligibility check because I think that such a huge percentage of denials, rejections are related to eligibility. It's 15% or something like that.
We've seen all the way to like 35.
Yeah, it's not uncommon. It's a huge problem, and HIPAA, administrative simplification, mandated that all health plans support the X12 270 271. And so if you see a health plan that says, well, you have to go through the portal, we don't have X12 support, they're violating HIPAA, and please contact us because we have an organization of people who work on those issues and work with CMS and payers to get those things resolved. But there's a loophole, which is that you can implement as a payer the bare minimum X12 270 271, and then you can have much richer information in the portal. And an example of this is you have a portal that allows someone to put in a CPT code instead of an STC code and get the benefits, specifically for that and the prior auth requirements for that. The X12 standard supports that. CMS supports that. There's, others. I think Blue Cross Blue Shield of Texas might support that to some limited extent for prior auth or something like that. To me, I would say that the single thing to do is a mandated parity between the functionality you offer on your portal, be that a claim status check, an eligibility check, a claim, and what is on available in X12. Provided that the standard has a spot for it. If there's no structured spot for it, it's the missing tooth clause in dental, it's fair game. You don't have to put it in. But if there's a structured spot for it, you have to put it in.
I'd say that plus by phone.
Anything available by phone, that'd be great too. Yeah. Alrighty. Well, this is great. Thank you for coming on. We're huge fans of what you guys are building and appreciate making the time.
Appreciate that. The feeling is mutual.